Welcome to the Cutting Edge Health Podcast with Jane Rogers, where we discuss science to help prevent cognitive decline.
Hey everyone, thanks for making the time to join us. Whether you're listening to the audio podcast or watching the video version on YouTube, we're glad you're here. Our guest for this episode is Dr. Nate Bergman, who is the Chief Science Officer at the Kemper Center for Cognitive Health and Wellness in Cleveland, Ohio. He's one of the preeminent brain health physicians in the U.S. Where conventional Western medicine believes that all they can offer Alzheimer's patients is palliative care, Dr. Bergman has seen up close how cognitive decline is treatable and reversible. Today, he discusses a wide range of interventions that can slow or reverse this insidious disease. Dr. Bergman, thank you so much for joining us here on Cutting Edge Health Podcast. I really appreciate your time.
Yeah, it's good to be here with you, Jane. Thanks for having me.
You see a whole bunch of people come into your clinic with cognitive issues. Tell me about what your days are like. Tell me about some of the things that you are seeing now to help them.
Yeah, I think the first thing that's really important to understand is that, cognitive decline used to be, and I think many pockets is still sort of considered something that you wait on. That we wait until, you kind of got to take the keys away from dad or a spouse. And there's this sort of remains this kind of prevalent notion that there's nothing you can do, so we just wait. And part of what we do at Kemper and in general with our podcast, etc., is get the word out. No, there are things that you can do, as you know, well in advance, because when you're talking about something like Alzheimer's and potentially other dementias, even if you say the word Alzheimer's, people don't think like a 55-year-old that's having trouble finding words or becoming less efficient at an office, even a 65-year-old. Typically, what people picture is, as I think you're pretty familiar with this, someone who is in a nursing home, who's got drool coming out of their mouth, and they don't recognize their spouse, maybe their children, and that's people's notion and concept of Alzheimer's. And so I think it's much more useful to think about Alzheimer's like we think about cancers, where we're looking in stages, right? So if I tell someone, oh, so-and-so has cancer, usually people's first reaction is, oh, that's terrible. And then for people that have a pretty good amount of health literacy, or they kind of understand what cancer is, or they know about it, what kind, right? Is it breast cancer? Is it colon cancer? Is it prostate cancer? What kind is it? Because that means something to a lot of us. And then we say, well, how far along is it, or what stage is it? And I think we probably have to, and a lot of the field is shifting to thinking about cognitive decline as how far along, right? Is this in sort of the early stages? Is this in a milder stage? Or are we now talking about dementia, which is when usually people invoke the word Alzheimer's, to them, it's synonymous with dementia. So dementia really means that someone has a cognitive issue that's so profound. There's so much loss of brain and brain function that people can't get through their day independently. They may not be able to use a phone. They might be able to pay bills. Maybe if they were once driving, they couldn't drive anymore. And that's obviously life-changing, game-changing kind of loss of independence. But what we're trying to do is get people aware that these changes typically happen much earlier. So 3, 5, 10, 20, maybe 30 years in advance. So if someone's parent developed Alzheimer's around 75, we should probably be thinking about looking for ourselves around age 45 or 50. And so like that, it's a very different way than many of us were could have raised or trained to think about Alzheimer's or cognitive decline, is looking early. So I think that's the biggest message, is that look early, because there's a lot you can do.
So look early. What are some of the things that someone should do to look?
So the simplest things that are not being done are look at your blood pressure. right? Look at the diet. Now, this typically someone who's listening to a podcast like this is really familiar with sort of the edge of medicine, the limitations of what they can get in, let's say, a primary care office or a geriatrician's office or even a neurologist's office. But I still feel like, because sometimes the more edgy the healthcare environment is, or the consumer of healthcare, people still overlook basic things like blood pressure. It's such an easy thing to get a number for. And I guess maybe you wouldn't be, but I'm still shocked by how many people will invest in $60, $80, $120 of vitamins or supplements every month sometimes, but are not aware of what their blood pressure is. Blood pressure is really a tremendous way to sort of save your brain, if you will. The higher the pressure is, let's say some of the magic numbers you get in once we get to be full-grown adults in the second half of our lives, whether that starts at 35, 45, 50, whenever that starts, we'll probably want to be looking and shooting for blood pressures, like still in the 120 ranges. We'll let it drift up into 130s, but once that top number gets, the systolic blood pressure gets above 140, and then the bottom number starts to trend consistently in the 80s and certainly into the 90s, you have to stop and think, what's causing this? And some people, it's simply wear and tear over time. Obviously, we want to look at the basic things like smoking. Are people exercising? And if they're exercising, can their exercise be optimized? Is there more room to improve? There's, again, as your crew and crowd know, there's all kinds of room to improve with dietary strategies, like the foods that we eat. Things that are, you can use therapeutic diets. Vegan diets, sort of a therapeutic diet. A ketogenic diet might be a therapeutic diet, and then when those are kept up at an extreme for long periods of time, they might have a side effect. I could go down the list of basic stuff, but smoking, drinking too much, not sleeping enough, not exercising kind of the right way, not keeping someone's brain challenged and active. Those are some of the most basic things. They're probably not news to anybody, but it's really kind of surprising on the basic level, like what people are not aware of. And then if you get into sort of someone like you, I remember when we first met, you had, it was like a 30-column Excel spreadsheet where you had all the values of labs and so I have a number of patients like that are very organized and are able to assimilate information for themselves, and then continue to read and continue to be active. And for those kinds of folks, so I think the difference in what we can provide as a physician is a more of a sounding board, right? Because there's a lot of stuff that's experimental, and it's amazing how people kind of run around talking about how things are proven or disproven. And I think over time, what the people that choose to continue to work with me as a physician, or really many of the physicians that we're familiar with, is to provide information, to provide sort of a consultation information, to be a sounding board to think through issues. Because there's a lot of stuff in the healthcare community, I think on the traditional side, where people are not open. You get a neurologist saying nutrition doesn't matter when it comes to Parkinson's, or nutrition doesn't matter when it comes to Alzheimer's disease. And those people are sometimes working, board certified at very, very well credentialed institutions. I've heard this kind of over and over, and nothing could be further from the truth, right? It's just not the kind of evidence they're used to being able to slide into a 15, 20-minute office visit. And on the other side, I think there's treatments in the so-called alternative or functional medicine community that are touted as highly effective and have evidence, when the kind of evidence they have is not the kind of evidence people are used to. Meaning it's never been used on a human being or something like that. Like we have one and a mouse trial with it. So, I find myself often somewhere in between those two, and maybe that's no man's land sometimes, where there's no person here or there. We don't have necessarily always a team. But the main thing that we're trying to do is improve the lives of patients. And everybody has a different level of appetite on the patient side, and as individuals, I think we all have a different appetite for the amount of time, energy, and resources we want to spend on this. So we're always kind of looking for, are there ways to simplify? Are there ways to simplify? Because that's the most important thing in the sort of ultra busy, ultra fast modern world. The simpler we can get interventions that people can do with a consistency, especially early on. If you're talking about prevention, starting at 45, 50 years old, those are kind of the key things. What can people sustain and maintain over time?
So what are you seeing in those people who come in early that has really worked to help change their trajectory? What are like a couple things that come to mind? Oh my gosh, I did this and Susan got so much better in a couple of years. Shoot.
So always, if somebody hasn't messed around with their diet yet, meaning they're still sort of eating a standard American diet, always see people get better just with basic stuff, getting processed foods out. So things that spike the blood sugar, really anything that comes out of a bag in a box, we try to keep it simple. Processed foods, and the addition of vegetables. Of course, we like people to have kind of like an addition of organic vegetables if possible, but
and no gluten.
Well, people saw no gluten or no dairy or no, like, I wouldn't say that for everybody. I wouldn't say it's just not a place that people can start for everybody. But if someone's already up and disciplined enough to kind of get rid of processed food, then we can see. So I'll tell you an interesting story about gluten. So we have a patient of ours now. He's in his early mid 70s. Brilliant person, came to see us from out of the country, and a story of really just a lot of toxic exposures because of jobs he was involved in as an engineer, and it's kind of this brilliant and amazing family, very, very proactive. But this man is very demented. He's had years of high blood pressure, years of high cholesterol that were kind of incompletely attended to and incompletely dealt with. So he's got really a lot of brain damage on a long journey to come to see us in Cleveland. And, this is a man who's so demented that when you just ask him to kind of, from a sitting position right next to a chair, ask him to sit down, not able to sit down, not able to sort of get organized enough to follow a direction to sit down. So, quite far along, full care in terms of his Alzheimer's and vascular dementia. And so typically we would start pretty simply with this, try to get the processed food out. And he was already eating a fairly healthy diet. But when we kind of took a fine-tooth comb through a 3-day diet journal, which is a really nice hack that people can do. Like if they want to really know what they're doing, really know what they're eating, literally writing, or in some places we'll take pictures, sort of a pictorial diary, if you will, of the food that we ate. It tells a whole different story often than what people think they're eating day to day, because they failed to mention when they grabbed this or when they grabbed that, or it was 10:30 at night and they grabbed something, or a second or third glass of wine, etc. So those are the kinds of things that add up. But like if someone has already given up processed food, etc., like these people, when they were staying in Cleveland with some family, the family members were gluten-free. And this is a person, the patient in his 70s, who's with really sort of advanced dementia, Alzheimer's dementia, really had no choice other than to be gluten-free. This is typically just eating what's put in front of him. And what they saw was within 2 weeks of having this gluten-free diet, and this is not typical, I don't see this with everybody, but he experiences night terrors. So this is something that runs in his family. Will wake up in a nightmare, sometimes hysterical. So sleeping improved, didn't need any sleeping medicine, and nor did he need melatonin. And it's just a supplement hormone that we often give to help people sleep. And he was remembering things with more ease. He remembered who his son was. He remembered who his daughter was. He recognized the voice of a family member on a phone call.
From just 2 weeks.
How do you explain that? So we don't see that with everybody, and I can't get everybody to give up gluten. It's just not. It's not in the realm of possibility in terms of a starting point for some people. But yeah, I mean, cutting out things that are typically inflammatory. This idea of food sensitivities. So whether it's gluten or it's dairy or it's soy. We had just another kind of amazing story of a person that had decades of chest pain and stomach pain, went on an elimination diet with our dietitian, and the guy was on like 7-8 medications, and stomach has radically improved with simple breathing exercises. A lot of his chest pain that he needs benzodiazepines for, which can, as you know, like something like Valium or Xanax. Those are benzodiazepine families of medicines. So those have gone away. So food, breathing exercises, checking blood pressure, those are things that people like. And then the other huge one, as you probably know, is exercise, right?
Yeah.
And exercise is not it seems simple because, we all kind of know what's good with exercise. But when it comes to cross-training the brain, we like to think about exercise in kind of 3 bins. Enough, and the exercise trials are, by the way, are coming for doses in terms of prevention for Alzheimer's. And to start, it's like, just getting into your body, right? Just getting into movement and getting comfortable with any kind of movement or exercise if someone's not sort of a lifelong exerciser is important. But then when it comes to cross-training kinds of exercises that are really good for both mood and the development of a healthy brain and body. And we like to say the brain body because the brain is in the body, right? The body is part brain, like our whole body. It's not just the brain up here.
So what's an example of a cross-training exercise?
So there are 3 kinds of exercises when we talk about cross-training exercises. There's cardiovascular. And we talk about resistance. So cardio-aerobic, cardiovascular, so the Jane Fonda, or that's the kind of classic. Then there's, we think about resistance, high intensity, if possible, but resistance training. So where you're pushing against something, it could be something like as simple as push-ups, sit-ups, and then certainly weights in that category. And then third, it's like motor and coordinative, right? And so this, maybe maybe you're not familiar with it, Jane, but most people think, let's say the back of the brain, there's a little bump on the back side of your brain, like on the back side of your head, there's an area in the brain called the cerebellum. And the cerebellum is sort of long known for, that's the center of coordination and balance. But it turns out that's only about 40 to 60% of its function. It's actually much more involved in executive function, making decisions, helping us stay efficient with work, mood regulation than we once thought. So even things like, anything that has steps, coordination. So Zumba is actually a good idea. Any kind of dance might actually have the most data for this kind of for these advantages to the brain. Even yoga and Tai Chi have some or confer some advantage. So that I think the ideal workout plan is some combination. What I do for myself is we try to do 2 days plus a week where we're doing weight. We're doing weight training that also has core and then cardiovascular as well. 2 other days a week at least where we're doing some kind of balance, motor, and coordinative training. So I'm a dance fan. We have a bunch of kids. Sometimes we'll try to do dance parties at home. And then, walking is still good. Walking is probably not adequate enough to really move the needle. It's kind of a maintenance. But walking with vigor, anything you can do with real vigor to get your heart rate up, to sort of get huffing and puffing, to get that sort of that level of what we call moderate intensity, to get that level of intensity, something beyond the regular intensity, as many days as possible from the week. That's the goal.
Does something that crosses the midline work well, like ping pong, crossing the center line? So you're using coordination for something like that. Is that
so? Racket sports. Almost every form of movement, like you mentioned, martial arts, Tai Chi, yoga, all of those things will cross the midline. And if you participate in classes, like you'll see that the brain seems to like wired up better. If you can do that, like crossing the midline, like you said, taking your right hand and crossing over to the left, there's a good, pretty long existing literature on how that's helpful. We're also getting into like primitive reflexes exercises with some of our groups as well. There's when you talk about these kinds of what we'll call bottom up approaches from the body that have an influence in the brain, there's quite a bit that can be done. And crossing the midline, is one of them. I don't know if it's just as simple as crossing the midline. I mean, that's what physical therapists are using, occupational therapists using, post-stroke recovery. There's been quite a bit known on that. And then when you add that, you combine those kinds of things with the other pieces. So the choreography piece in dance, or just movement and expressive dance, or yoga or Tai Chi, like you're going to get these sort of combinations of benefits.
So you have diet, you have exercise as two of the major interventions right away if someone comes in. What's your third one?
Yeah, so it depends on someone's story. Like we usually have to ask what's going on with people, but either sleep or stress is the third one. Sleep or stress is the third one. And usually these are pretty intertwined, because a lot of times if people are struggling with stress, and most people over the last, lived through 2020, had some, like there was definitely a shift in sleep and definitely stress for people, like high stress or high cortisol. So stress being defined as changes in our external environment or internal environment, but typically it's our external environment that require energy, require quite a bit of energy for our nervous system and immune systems to respond to. Our minds and brains are programmed for stability and certainty. So we seek stability and certainty. We seek evidence. We seek simple answers, or predictable answers, at least, if they're not simple. And so usually we have to talk about what's stressing someone out, or why are they not sleeping. So stress can be a tricky one, because there's stress that's inherited. There might be stress that's generational, things that happened to people growing up that have been either ignored or incompletely dealt with, or and they continue to create like patterns of behavior or of thinking or emotion that can be harmful. So the adverse childhood events study, that was the original data was done, in Kaiser in the 1990s. I think a lot of people have heard of ACEs or ACE questionnaires. So let's say they boiled it down to on some level. So there's a lot of layers to this study, but the basics is 10 questions. Like, hey, did you have someone that would hit you, slap you growing up? Would your parents get divorced? Were you around people with a mental illness or alcoholics, drug abuse, etc.? And if you get, the magic number, if you have 4 or more on an ACEs questionnaire, and you can just Google ACEs and see what your score is, like there are all kinds of associations to diseases, disease states, or abnormal health outcomes, among them dementia. There's, according to one study, there's like a 6.5 times increase if your score was 4 out of 10 or more, 5, 6, 7, 8, 9 out of 10. There's like a 6.5 time increase of getting dementia, right? So there are things that are incompletely dealt with, those kinds of stressors, and there's stressors that are happening actively, right? Actively, and there's all kinds and flavors of stress, and it's probably for like a different podcast interview. But we do a lot of referral for therapy, movement therapies. I'm very big on movement therapies, but then just talking therapy, and then learning how to breathe. Learning how to breathe is almost like a forgotten art, right? In the days where I'm staring into cameras all day, I'm staring into a Zoom machine or like a computer all day, and I usually have a watch or a ring that tells me when I should stand up, remind me to stretch my legs. It's all good. So we're relying on technology to kind of help us adapt, and that's actually a nice adaptation. I think the sort of extended embodied cognition, or the idea that we have some technology that extends beyond our own nervous system to help us adapt to the stress. And then on the sleep side, sleep one is a huge, it feels like an uphill battle right now, because we do a lot of querying for, it's over 100 sleep disorders.
Really? That many? Okay.
Worldwide. Yeah, but the two commonest tend to be insomnia and sleep apnea. And insomnia, people usually have a pretty good sense of if they sleep well or not. But the sleep apnea is the one we find missed quite a bit. And I would say, I don't know the numbers right now, but probably I have a pretty low bar for my patients, a pretty low threshold to send someone to a sleep doctor for, let's say, a sleep study or a sleep evaluation. There are some gold standard things that people can do, like an Epworth sleepiness scale. You can go out and just, Google Epworth sleepiness scale, see what your scores are. How easily you fall asleep, how tired are you during the day? Do you wake up with, sometimes people wake up with headaches, but more and more attention is being paid to the entire airway. So I'll almost always look in someone's mouth, see if they have like a patent airway. If the airway looks small, meaning you look in the back of someone's mouth, and this is something you can Google. You can Google a Mallampati score, Mallampti, Mallampati, or Pati, excuse me, Mallampati score. And, this is something that anesthesiologists use typically to see if someone's going to be a difficult intubation, right? Because the anesthesiologist, part of what they do is under surgery or when someone's under anesthesia, they have to keep people breathing. So they have to put a breathing tube, they have to put them on a ventilator, basically. And so they are experts in seeing, is this airway open? And when you look in the back of someone's mouth, the less of the soft palate, the less of the uvula, which some people think of the tonsils, but it's the uvula hanging down, the less you can see in the back of that mouth. There's like 4 stages. The higher, like if you're stage 3 or 4, sometimes that's an indication that the airway is smaller, and then there might be less oxygen getting down into someone's lungs and into their heart, their brain, their blood system night over night. And so we send people to probably more than others to a sleep doctor for evaluations. And then even when people get sleep evaluations, and now I'm talking more about people that are already a little bit sick, they have mild cognitive impairment, which is a pre-dementia, pre-Alzheimer's state, or they have full-blown, they're in sort of an early stage of cognitive impairment, of Alzheimer's, or other kinds of dementia. If they have these, right, that means if they have something like an obstructive sleep apnea, that means every single night they're not getting fully restorative sleep. So that means, one way of thinking about that is every single night they're getting a little bit of brain damage, which is a problem, right? And so they'll oftentimes go to a sleep doctor, get a sleep study, and it'll say sort of a mild sleep apnea, and they'll be told by a sleep doctor saying, well, just a mild problem, it's not an issue, it's not worth treating. And if someone's taking a proactive stance or they're either trying to prevent or they're in the throes of a problem, a cognitive issue, to say that a little bit of brain damage every single night is okay, probably to me in my mind is an inadequate answer. And so that's an area that sleep medicine is an area where right now it feels a little bit uphill, because sometimes even when we'll refer people to sleep doctors and they get their sleep evaluations, still people are sort of waved off as it's no big deal. It's no big deal. And I understand the perspective of it's not being a big deal from there, but when you string together these sort of little hits, these little tacks on the brain over time, 5, 10, 15 years, that might add up to quite a bit of damage.
It's a big deal. So with your patients, have you seen success with a Cpap or with dental work to actually try to increase the size of that palate in the back?
Yeah, both. I think it's just what people are up for. Sometimes people just get a mouthpiece from CVS. They'll go to a dentist, like a American Academy of Dental and Sleep Medicine dentist, fellowship trained person, where they'll get a mouthpiece. Sometimes it's a mandibular advancement device. There are other light wires, ALF, and there's a lot of other approaches that may be not standard. But there's quite a bit that people can do other than a Cpap machine. Although CPAP machine is still gold standard, we've had many patients have procedures, surgeries, and like usually what will happen is, to answer your original question, when people come in with a subjective issue or they're having cognitive issues, and if they haven't tried any of the what we just talked about, the vast majority of people are having improvements, within a couple weeks, a couple months, and certainly if they're continuing the kinds of changes, they're sustaining the kinds of changes that we've just talked about, they'll have, they'll kind of get better and better. Like it's amazing when people act early, how much they can improve.
You got the best job in the world. You really do. You're helping so many people. So as you look into the future with this issue, what's on the horizon? What do you see that will be able to help us in a year or 5 years that are already in clinical trials?
Yeah, well, I mean, you're talking about for Alzheimer's or?
Mm-hmm. Mm-hmm.
Yeah. So I do think we'll probably have medicines pretty soon. I mean, like the aducanumab, the Aduhelm, the one was approved. I mean, I understand why people wouldn't want to use it. But if you're sort of the kind of person that's like, hey, medicines is my thing, and I'm not going to do any of the changing my diet, etc. So you're just going to wait around for the medicine. So I do think that medicines are kind of on the way for Alzheimer's. I don't think it's that new, but I see people getting more serious about it. Fixing dental issues, particularly periodontal issues. So the parts of the teeth that kind of surround the actual teeth, those can harbor the kind of inflammation that will hold on to infection. Will hold on to infections, or at least organisms like bugs that are associated with brain disease and heart disease. And
so
other
if you have
things.
a root canal that doesn't go right, it might harbor some of those problems. Mm-hmm.
Yeah, or just like periodontitis, like periodontal disease, where there's sort of inflammation going on right below the tooth level. So, and these are things, again, like they're not as a sort of like sexy as some of the latest and greatest, but they're super, super correlated. And when people do these, like I'm sort of the opinion that if it's real, like if the data is there, it should also work in real life. Like when people do the treatment, they should feel better, right? Assuming that it's sustained long enough. And so this is one of those that we've been hip to for a little while, but I hear from some colleagues that are more and more aggressive about fixing some of the dental issues, that when they fix dental issues, sometimes we see both issues, not just of brain, but also of mood. That mood can improve, which is interesting too. Things like anxiousness and insomnia may have some improvements. Other things that we're like excited about, and this is, I think it depends on who you're talking to and kind of where they're at, what stage of if they're ill or not. And it seems, again, these things seem cliche, but we hammer on them. We go over and over and over and back to them because they're basic and they work. When we're working with people, let's say that are brought, we're talking about prevention, or we're talking about intervention for people who are already sick with things like Alzheimer's here?
I'm talking about prevention.
Prevention, okay. Yeah, so being really clear on why am I doing this, right? What's my level of commitment? Because most of the reasons that people fall off are not because they can't do stuff. It's mostly because they're not clear on why am I doing this, right? If I have to say no to, even if I don't dairy, but I have to say no to like the next scoop of vegan ice cream at night, right? Why am I doing that? Why am I doing that? Because I don't want the damage. And if you're someone who's in a position where you can check, let's say your blood sugar, you can get either a continuous glucose monitor, or you can just get for $50, $80, $100, you can go to CVS, Walgreens, or Amazon and get like an ability to check your blood sugar. And you start to check your blood sugar 30, 60 minutes after 90 minutes even after you eat. And you're like, wow, I had no idea that after I eat white rice, my blood sugar spikes to like a diabetic range, right? What can I do about that? Or you get something like an Oura Ring, or something that is measuring your HRV, your heart rate variability, which is, one sort of measure you could think about of our body's ability to handle stress, is one way to think about that. When you start to get that kind of information, and it's simplified and usable, you can start to do some of these hacks for yourself. And what we'll see is, even sometimes, like people listening to a book, listening to someone's voice, and it doesn't have to be in guided meditation, but it's sort of focusing people's minds kind of on the here and now and in a trajectory that has purpose, you'll see some of these parameters change. In other words, blood sugar is affected by our exercise. Blood sugar is certainly affected by what we eat most directly. But then also the mindset that we carry, how much sleep we're getting, like all of these things will impact stress numbers, cortisol, heart rate variability. And then over time, the improvements in those areas and those parameters are kind of equal or approximate to improvements with brain. So like just getting simple feedback information on a watch or on a ring or something like that, and then thinking about the things that you're doing so that you can tweak them, and then having groups of people that are thinking about these with you as well. So a podcast like this, where you have like a group of people, you kind of curate a group of people that are looking at these things, can be really, really helpful.
It's all about community. If we have support around us, we can really succeed with this. If you're all by yourself, it's a lot harder.
Yeah, because you can run products by each other. Where can I get this? Where can I get that? Cheaper, like all the stuff people know. And then the other thing that we're, I've been pretty excited about that I would say we're at this point beyond the kicking the tires on is the use of technologies that can accelerate changes in the brain. So, like for our podcast, we haven't released the episodes. I just interviewed Ben Hempstead, who's a NIH-funded University of Michigan researcher that is funded to study kind of like, you can think about like the aging brain. Our brains all start to age from the time we're in our late 20s, as you probably know. So we all have, probably all of our listeners have an aging brain, right? So there's very few people that are probably listening to us that are older than 20 or younger than 27, 28 years old. But there are more and more. There are more and more people thinking about this at a young age, which is kind of exciting. But we're thinking about how do we influence the activity of an aging brain. So just like over time, just like our joints, our skin, our muscles get older, so does our brain. And a feature of an aging brain is usually that there's certain things that are more difficult, right? It's a little bit are the sort of the total miles per hour, the speed of the brain, processing speed, overall speed is called a posterior dominant rhythm on like an EEG or on like a kind of test that will look at how someone's brain is functioning in terms of its overall speed and efficiency. When we start to see that, there are technologies that you can use in addition to changing diet, exercise, sleep, stress, all of the kind of basic stuff, checking labs, inflammation, hormones, etc., all the things that I'm sure you'll be talking about on this podcast. There are still more things you can do that are, it can be relatively simple in some cases. By adding energy to the brain in areas that the brain can be influenced the most, right? We are one of the most exciting things we're talking about now is the field of connectomics, right? People know about a microbiome, and some people are learning about a connectome. But the connectome being sort of the totality of connections that we have in our brains and nervous systems, right? What's sort of shaking out of this is that our brains work and make decisions and think in networks. And what we mean by networks is sort of like committees. So just like you have, in order to pass something, let's say in healthcare, you have an idea, but then you got to go to Congress and you got to go to the Senate, you go to the Senate Finance Committee, you got to go on the House side, you got to go to Health, Education, Labor, and Pensions Committee and Ways and Means, and you have to find even in those committees who are the most influential members, and lobbyists influence at those sort of influential points. So there are technologies now that can get a sense of where the breakdown is in the networks of these brains, and then where we can add small amounts of energy, sort of safe amounts of energy to those areas to get a positive effect. An example of this is like the V-Light, VIELIGHT. It's a Canadian company. It's sort of under the the auspices or the umbrella of something called photobiomodulation, low-level light or low-level laser therapy. Oh, you're going right there, yeah.
Got one, yeah. It's exciting.
Yeah, and so we see sometimes these really startling, staggering improvements in people that are sicker. And then people that are younger that are just trying things, right? So we use transcranial direct current stimulation to improve working memory. We have an environment we developed where we're taking people that have cognitive impairment that are really trying to stay at home. And we're training them for 2 hours with everything we're talking about. Exercise with dual tasking. So we're giving people both intense physical exercise across the domains that we talked about before, cardio aerobic, resistance, and motor and coordination. But they're wearing technology that accelerates their learning. Right? And then we have a cognitive curriculum, another hour of cognitive curriculum where we're training aspects of thinking, memory, working memory, visual spatial reasoning, visual memory. That's like all different kinds of aspects of mood and of mind and brain function that can be measured. And they're wearing some of the technology that you just showed, the V-Light. And then we're collecting data over time, and we're trying to confirm what we've seen kind of anecdotally, that when people do this work, they can enjoy more independence for longer periods of time and really push back and not just accept the idea that cognitive aging is inevitable. Right. Mm-hmm. And so like this guy, Ben Hampstead, Adam Woods, and then October, there's people all over the country and really the world that are doing this at an academic level. So that was like, for me, it was a really kind of a fun interview to see that we were, we're tracking in the same direction as some of these serious neuroscientists that are at academic affiliations.
Dr. Bergman, you've been so kind with your time. Thank you very much. So if someone is watching or listening and they want to get a hold of you, how can they?
They just go to KemperWellness.com. It's thank you for asking. It's Kemper with a K, Kemper, wellness.com. And we'll be happy to talk to you.
And can you talk to someone like on Zoom from anywhere in the country, or do they have to drive to Cleveland?
Yeah, so if they want to be a patient, they definitely have to come in. But we can talk to anybody in a consultation, sort of an informational way, from anywhere.
Over the phone. Okay. Yeah. Thank you very much.
Yeah.
You have a great day now, okay?
Yeah, you too.
You've been listening to the Cutting Edge Health Podcast, created and hosted by Jane Rogers. The website is cuttingedgehealth.com. We hope you enjoyed the show and would very much appreciate your writing a review. They help a lot, and we read each one. Any information shared on this podcast is for educational purposes only. Guest opinions are their own. This podcast is not responsible for the veracity of their statements. The comments expressed are not medical advice. Do not use any of this information without first talking to your doctor. This podcast and Jane Rogers disclaim responsibility for any adverse effects from the use of any information presented. Thank you for listening and have a beautiful day.